So what am I going to talk is a very, very broad approach to adrenal incidentaloma. It is such a common condition nowadays. So I thought I will give you a bird's eye view. Just how to go about when you see a case of adrenal incidentaloma. The scope of this lecture will not allow me to go into the details of the management of each condition. So I'll just be touching about the approach. Here I am tempted to quote the words of H.L. Mencken. War will never cease until babies begin to come into the world with larger cerebrum and smaller adrenal glands. I'm sure you all agree with me that this is such a apt statement considering all the strife within our country and internationally. So hopefully future generation have larger cerebrums and small adrenal glands. Before I go any further, I always like to express my gratitude and thanks to my father, Professor Swittel, who's not only my father, teacher, mentor, and guide, he's my role model and my inspiration. Obviously, you all know that he's the founder, president of our organization, IAES, which was founded in the year 1993. To come to the topic proper, it was two endocrine surgeons called Keel and Drui who coined the term incidentaloma in the year 1982. And you must understand it was during this period, ultrasound was the main imaging tool and CT scan was just coming into vogue and was being started using a little bit more commonly. And there was a new problem which they faced at that time when they imaged with ultrasound and CT, they found a lot of these incidental tumors. So how will you define an adrenal incidentaloma? It is an asymptomatic adrenal mass more than 1 centimeter that is discovered serendipitously during the radiological examination performed for reasons unrelated to adrenal disease. When I mean serendipitously, it means accidentally discovered. So when you find an adrenal mass more than 1 centimeter, which is accidentally discovered during imaging for other reasons other than adrenal, it is called an adrenal incidentaloma. So briefly about the epidemiology, if you look at the prevalence, a summary of 25 autopsy studies, roughly the prevalence is about 6%. And this prevalence increases with age. Usually patients younger than 30 years, the prevalence is 1%, and patients older than 70 years, the prevalence is around 7%. If you take the abdominal CT, the prevalence is roughly 1 to 4%, and there's no gender bias in adrenal incidentaloma. Coming to the etiology, the commonest, if you see, is a non-functioning cortical adenoma, which constitutes probably 70 to 80% of all cases of incidentalomas. What are the other causes or etiology? Cortical secreting adenomas, pheochromocytomas, adenoma secreting aldosterone called Cons adenoma. These are in descending order of incidence, and the percentage varies from series to series. Of course, you have adenocortical carcinoma, which constitutes roughly 5%, adrenal mets, which may be unilateral or bilateral. You have the myelolipomas, ganglioneuromas, cysts, infections like fungal. These are uncommon or rare. Infection like fungal example would be blastomycosis, coccidiomycosis, histoplasmosis. Parasitic, of course, you have highlighted. Bacterial, you should think about TB. Syphilis is very uncommon these days. When you think about infiltrations, two conditions should come into mind. One is sarcoidosis and amyloidosis. This is not the end of the shopping list. You have other rarer causes as well, but this broadly gives you the etiology of an adrenal incidentaloma. It is important to remember 70 to 80% is a non-functioning cortical adenomas. So when you come to adrenal incidentalomas, the way I see it is a disease of modern technology. Is it a boon or is it a pain? On one hand, it offers opportunities for early diagnosis of secretory lesion or a malignant lesion of adrenal, and hence you can treat them appropriately. On the other hand, majority of the lesions do not cause any problem, and there's a risk of overdiagnosis, unnecessary investigation causing economic and mental stress to the patient. So what are the issues I'm going to discuss? I'm briefly going to touch about the following issues. When you find an adrenal incidentaloma, is the adrenal mass malignant? What are the imaging modalities to assess malignancy? Is the adrenal mass hormonally active or is it functional? In other words, pardon me, I got a chronic laryngitis for the last few weeks. What are the appropriate biochemical tests to detect hypersecretory states? What is the management of what was called previously subclinical Cushing's, nowadays called autonomous cortisol secretion? When to operate in adrenal incidentaloma? What is the preferred surgical approach? What follow-up is indicated if adrenal incidentaloma is not surgically removed? These are the issues which I'm going to spend a minute or two in the next following slides. The first issue is an adrenal incidentaloma malignant or benign. That depends upon two things. One, size. Two, morphology or phenotype on imaging. So when you come to the size is an important parameter which distinguishes between benign and malignant adrenal mass. If it is 4 centimeter or less, the risk of malignancy in an incidentaloma is around 2%. If it's more than 6 centimeter, the risk of malignancy is 25%. So the larger the adrenal mass, the greater the size of or the incidence of malignancy. So tumor size is not the only criteria, but should be evaluated in the context of other radiological features. Next, coming to the imaging phenotype. So I said about size and two, imaging phenotype. CT scan is the primary tool for evaluation of adrenal masses. I want you to remember that benign tumors of the adrenal, in other words, adrenal adenomas, are usually lipid-rich, and lipid-rich masses have low attenuation on CT. So the lesions that have attenuation values of 10 or less on non-contrast CT are usually benign. Unenhanced CT attenuation value is a better predictor of benign tumors than adrenal tumor size. So this is I think you can see, this is a very typical adrenal adenoma on the left side. So when do you use contrast CT? 30% of benign tumors are lipid poor. So what happens because of that? When you image on a CT, the attenuation values are more than 10. So just because the attenuation values are more than 10, automatically it doesn't mean they are benign. So what will you do? You will then do a contrast enhanced CT. And what is the principle here? Benign tumors, or in other words, when you inject contrast, adrenal adenomas take up IV contrast rapidly. They not only take the contrast rapidly, the contrast gets washed away rapidly as well. This phenomenon is called contrast enhancement washout. So in benign tumors, you have a relative washout more than 40% and an absolute washout more than 60%. Your radiologist will calculate all this for you. So when you have this, usually you have a sensitivity of 87% and a specificity of 94% for benign tumors. This is a picture which shows pre-contrast view. And here you can see where the arrow is pointed. Contrast is injected and 1 minute view. And this is a delayed view where you can see how the contrast is rapidly taken out and rapidly washed out as well. So a typical benign lesion, the size is less than 4 centimeter. It is homogeneous in appearance, smooth margins, attenuation values are less than 10, relative washout more than 40%, and absolute washout is more than 60%. This is a typical benign lesion on a CT imaging. So when will you use MRI? In other words, what are the advantages of an MRI? One, there's a benefit of lack of radiation exposure. Iodine-based contrast media are not required, and there is superior tissue contrast resolution. What is the principle of an MRI? Chemical shift imaging is used to differentiate benign from malignant adrenal masses. What do I mean by that? In the presence of magnetic field, protons in water vibrate in a different frequency when compared to protons in lipid. In other words, protons in water oscillate in and out of phase with respect to protons in lipid. This principle is used to differentiate between a benign and a malignant adrenal mass in an MRI. When is MRI indicated? When you do a contrast enhanced CT and still the radiologist thinks that the adrenal mass is indeterminate, or you cannot use as iodinated CT contrast, then you will go in for an MRI. And this is what is seen. There's a loss of signal intensity in out of phase images when compared to in phase images. This is another typical MRI of the adrenal, with showing a benign adrenal tumor on the right side. In selected cases, you do a FDG PET CT where there's a history of extraadrenal cancer and you want to find out whether the adrenal incidentaloma is benign or malignant. You might do it, not done routinely. We finished about whether the mass is benign or malignant. Next, we'll go to the next component. Is the adrenal gland hormonally active? In other words, is it functional or not? In other words, is it hypersecretory or not? For which you need to take a good history. There is no substitute for a good history and a detailed clinical examination. All adrenal incidentalomas require biochemical evaluation to exclude excess hormonal secretion. Here, I would just like to introduce a term called subclinical Cushing syndrome. This was a term introduced in 1981. What is the definition? There is subtle autonomous production of cortisol from an adrenal mass, which is usually associated with suppression of cortisol from the contralateral gland, but with no overt clinical features of Cushing syndrome. In other words, you must remember there are three components. There is a subtle autonomous production of cortisol from one adrenal mass. Point number two, it suppresses the cortisol from the other gland. Point number three, there is no overt features of Cushing syndrome. This subclinical Cushing syndrome is nowadays called autonomous cortisol secretion, which I think is a more appropriate term. Usually it is seen in 5 to 8% of adrenal incidentalomas, but if you take many series, some series say 10%, some series say 20 to 30%. It varies from literature to literature. Few more words about autonomous cortisol secretion. Why is it important? Because it has been found that autonomous cortisol secretion has been associated with hypertension, impaired glucose tolerance, type 2 diabetes mellitus, dyslipidemia, obesity, osteoporosis, and risk of vertebral fractures. There are some studies that says that because of all these, there is an increased risk of cardiovascular events and increased risk of mortality. So what do you do when you have an autonomous cortisol secretion? The first point you should note is, do all cases of autonomous cortisol secretion progress to Cushing syndrome? The answer is no. Only around 1% of cases of autonomous cortisol secretion progress to Cushing syndrome. So why are we worried so much about this? Because they are associated with the other comorbid conditions which are seen. We want to know whether we could do something for that. So there are two schools of thought when you diagnose an adrenal incidentoloma with autonomous cortisol secretion. One school says you can indulge in active surveillance. The other group says you can offer adrenalectomy. So the bottom line is, if the patient does not have any comorbid features like hypertension, diabetes, all what I mentioned, I think there's no harm in doing active surveillance. But if they have comorbid conditions, there are some studies which say, although this evidence is not robust, some evidence that doing adrenalectomy may improve the morbidity. It may improve the sugar levels, lower the lipid, bring down the blood pressure. Having said that, I think the decision to operate on patients with autonomous cortisol secretion must be individualized because there is still no robust evidence. Those who are having adrenalectomy should receive perioperative glucocorticoid replacement because of suppression of the hypothalamic pituitary adrenal axis. As I told you, the adrenal is suppressed. How will you diagnose? First of all, biochemical test. What is the best screening test? Is a humble and a simple 1 milligram overnight dexamethasone test. You give 1 milligram dexamethasone, I'm sure all of you do it, at 11 o'clock the previous night, and measure the cortisol levels at any time between 8 to 9 in the morning. If it is less than 1.8 microgram per deciliter, it is normal. If it is more than 5 microgram per deciliter, then it is most likely a case of autonomous cortisol secretion. The principle is dexamethasone is a potent steroid. You give a potent steroid in normal patients, it should suppress cortisols. Whereas in patients with autonomously secreting cortisol, it doesn't happen. Although overnight dexamethasone test is a very good screening test, if you want a confirmatory test, you can do a serum ACTH, 24-hour urinary free cortisol, or a late night salivary cortisol. What is a good screening test to rule out pheochromocytoma? You have to do either a plasma-free metanephrine or a 24-hour urinary fractionated metanephrine. You can see here the sensitivity of a plasma-free metanephrine is around 99%, and 24-hour urinary fractionated metanephrine is around 97%. You either do one of the two, or if the luxury permits, you can do both as well. Coming to corn-secreting adenoma, which needs to be ruled out. Do you have to screen for cons in all case of adrenal incidentoloma? The answer is no. When adrenal incidentoloma is associated with hypertension or is associated with hypokalemia, then we are duty bound to rule out hyperaldosteronism. And what will you do to pick up such a case? You will have to measure a plasma aldosterone concentration. You have to measure plasma renin, and aldosterone will be elevated and plasma renin should be suppressed. You have to demonstrate the elevated plasma aldosterone and suppressed plasma renin, and the ratio should be more than 20. That is the aldosterone renin ratio should be more than 20 with the aldosterone concentration of more than 50 nanogram. Then it is most likely that you are dealing with a case of cons. Beware, before doing this test, you should make sure that the patient is not on any AC inhibitors, ARB, that is angiotensin receptor blockers, or potassium sparing diuretics like spironolactone, because then you will have a false negative. You also have a false positive when the patient is on beta blockers, non-steroidal anti-inflammatory drugs, or the patient is on oral contraceptives or estrogen. So with this caveat, you can do this and you can rule out a con syndrome. Coming to sex steroids or hyperandrogenism, where will you routinely do or measure sex hormones in a case of adrenal incidentaloma? I don't think it's routinely indicated measurement of sex hormones and steroid precursors. You will do it when you image or there are clinical features suggestive of adrenocortical carcinoma. So when you examine, when you see that there are clinical features of steroid excess or sex steroid excess, or when there is imaging features of adrenocortical carcinoma, you will want to measure sex hormones. Why? ACC is associated more than 50% of cases with elevated sex hormones and steroid precursors. Normally, you'll do a DHEA, that is dihydroepiandrosterone sulfate, androstenedione, and maybe a 17-hydroxy progesterone. This would be the basic sex hormones you would do. Right. We have come to the diagnostic part. So far, what have we done? We know what is an adrenal incidentaloma. We know that we have to image, and based on the imaging phenotype and the size, decide whether it is likely to be benign or malignant. Then, when you have adrenal incidentaloma, we now know what are the tests we have to do to exclude a hypersecretory state. Having done it, we should know when you should submit the patient to surgical intervention. One, all functional tumors, irrespective of size, need surgery. Two, when the imaging characteristics points to malignancy, or when the size is large, more than 6 centimeter, you will advocate surgical intervention. As I mentioned earlier, functional tumors, you will operate in autonomous cortisol secretion. I have given you the pros and cons. If there are no comorbid features, maybe you can actively screen them. If there are comorbid features, then you can give the patient the option of surgery, but it should be a personalized, individualized decision. One size does not fit all. Imaging characteristic wise, what are the suggestion of malignancy? More than 10 Hounsfield units, delayed washout, heterogeneous appearance, irregular margin, areas of necrosis, evidence of local invasion. These are pointers to carcinoma. This is what a typical feature of a ACC you will find. I'm sure many of you would have seen an ACC. With relation to the size, when it comes to surgical intervention, less than 4 centimeter, you would follow up. More than 6 centimeter, definitely surgical intervention, because the risk of malignancy is more than 25%. 4 to 6 centimeter is a gray area. Criteria other than size should be considered in deciding to observe or proceed with surgery. Having said that, there are more and more studies which say 4 to 6 centimeter, there's nothing wrong in offering surgery to the patients. Having decided about surgery, what would be a surgical approach? Laparoscopic adrenalectomy is advocated. When I mean laparoscopic adrenalectomy, I also include the entity of retroperitoneal adrenalectomy for incidentalomas of size less than 6 centimeter. What is the sanctity of the 6 centimeter? Even if the incidentaloma is malignant, it is presumed that we can remove the adrenal mass without rupture of the tumor capsule if the size is less than 6 centimeter. Because if it ruptures, there's always that risk of tumor seedling and recurrence. So size less than 6 centimeter, and obviously you have to make sure that there is no evidence of local invasion. You will offer open adrenalectomy if the size is more than 6 centimeter and there is evidence of local invasion. Having said that, as I mentioned earlier, an individualized decision process is required to find the best surgical approach for a given patient. These are all broad guidelines. Finally, you should treat that particular patient. and it also depends upon the experience of the surgical team, patient characteristics, patient wishes, local logistics. Everything should be taken into account. Right, you're not operating on the patient, you're going to follow up the patient. So how will you follow? What are the things you will do? Currently, there is no universally accepted consensus for a follow-up of adrenal incidentaloma. Why? You don't have much prospective data. Most of the data is retrospective in nature. So when it comes to follow-up, what will you do? You will once again do imaging and hormonal studies in your follow-up to determine how to carry forward. So what will you do in imaging? Here you have two guidelines which are commonly followed. One is the American Association of Clinical Endocrinology Guidelines / AAES guidelines, which was postulated in 2009, which has not been updated. So I think they are a little bit outdated according to me. What do they suggest? If you're going to follow up, you do a repeat imaging in 3 to 6 months and annually for 2 years. You will do surgical intervention when the tumor grows more than 1 centimeter. Next, you have the European Society of Endocrinology and the European Network and Study of Adrenal Tumor Guidelines, which was once again postulated in 2016, and they gave some robust guidelines based on an extensive review of evidence-based literature. And according to them, no follow-up is required in adrenal mass less than 4 centimeter when it is clearly benign on imaging. If it's an indeterminate mass, you will have to do a non-contrast CT or a MRI after 6 to 12 months. And if you do imaging after 6 to 12 months, there is no growth, then no further imaging is required. If you do a repeat imaging and if the lesion enlarges more than 20 centimeter or there's a 5 millimeter increase in maximum diameter, then you will offer surgery for the patient. This is based on imaging. With regard to the hormonal evaluation, what will you do? The AACE and the AAES guidelines say you'll first do at the time of initial diagnosis and you'll do annually up to 5 years. After 5 years, if everything is normal, you can stop. But what do the ESC and the NSAT guidelines say? If the initial hormonal workup is normal, no more hormonal workup is required unless there is new clinical signs of endocrine activity or there is worsening of comorbidities like hypertension or type 2 diabetes. I think this is more in tune with our logistics, because this makes sure that we do not unnecessarily waste our logistics. So to conclude, my younger colleagues, some practice points. Adrenal incidentalomas are more commonly diagnosed because of increased use of abdominal imaging. Management should involve an MDT team, which includes endocrinologists, radiologists, surgeons, and pathologists. We surgeons should not think we know it all. I think when it comes to incidentaloma, it should be an MDT decision. The first step is to aim whether to determine whether the lesion is benign or malignant, for which a non-contrast CT is the best investigation. And what will you see there? You will see the size and imaging phenotype. These are the two determinants which decide whether it is benign or malignant. Next, you will want to rule out whether adrenal incidentaloma is functional tumor or not, for which, for all cases of incidentaloma, you are morally duty bound to do an overnight dexamethasone suppression test You are duty bound to rule out FEO by doing a plasma-free meta-reference or a 24-hour urinary fractionated meta-reference of both. So for all incidentalomas, you should do the first two. Aldosterone-renin ratio, if the incidentaloma is associated with hypertension or hypokalemia, you will want to rule out cons. Sex steroids, when the clinical features which show evidence of hirsutism or evidence of increased sex steroids, or when you're suspecting ACC, you will do it. Surgical resection, when all hormonally active tumors, or if the size or imaging phenotype raises the suspicion of malignancy, you will do surgery. What is the preferred approach? Laparoscopic adrenalectomy, including retroperitoneal adrenalectomy for tumors less than 6 centimeter when there is no evidence of a local invasion. Open adrenalectomy for tumors more than 6 centimeter and locally invasive tumors. Having said that, one size does not fit all. You will have to individually base your decision based on the patient, based on the surgeon, based on the logistics, and so on. With regard to follow-up, there is no international consensus. You have the AACE and AAS guidelines formulated in 2009, and you have the European Surgical Society of Endocrinology guidelines formulated in 2016. These are the guidelines you can follow. This is just a rough algorithm. Finally, I think we all should have an institutionalized approach. You should know, in our institution, if you get adrenal incidentaloma, this is the protocol. And finally, I think we need to have our own regional or national guidelines based on the infrastructure our hospital or our region or our country has. And that would be the ideal. Thank you, one and all, for giving me a patient hearing. Thank